So that's the physical end of it. Let's talk about antipsychotic medication. Antipsychotic medication is called that imaginatively enough because it's trying to address psychotic symptoms. The psychotic symptoms that people have are in three main areas. You can be psychotic in three main areas. You can have a hallucination. A hallucination is a sensory experience that is not real. And it can happen in any of the five senses. So you can hear something that's not there, which is the most common in the Western Hemisphere. You can see something that's not there, or much less common, smell, taste, or touch something that's not there. Those last three, smelling, tasting, and touching, are called the proprioceptive hallucinations, because the first place to go when somebody has one of those is to get them a physical, because they either have an infection or they have a cyst or a mass that's laying on a cranial nerve and causing this experience. But hallucinations in those five areas are much more likely to be auditory or visual. Usually visual is associated with a dementing process, which we don't call dementia anymore, we call it a cognitive impairment, or cognitive disability. So you're going to probably have, as an antipsychotic feature that is a hallucination, something auditory that's not there. Infrequently voices, more likely sounds, phones ringing, crackling wax paper, mechanical ticking, animal growling, insect sounds, things like that. So that's hallucination. The second psychotic symptom is a delusion. A delusion is a thought that's not real. So it can't be validated. The most common delusion is a persecutory delusion, where somebody believes that they're paranoid because they believe that somebody's going to take something away from them that is important to them. Their reputation, a relationship with somebody, a possession that's important to them, and doesn't follow a logical process. There might be a kernel of reality in there, but everything else is not real. You want to really medicate hallucinations and delusions. And the third psychotic symptom, which is disorganization. And I'm not talking messy desk disorganization. If it was, I'd be on like 6 different meds. But you have to keep in mind that disorganization can be extended to the point where the person is not able to converse, they're not able to put a sentence together, they're not able to communicate their needs, and it is because of a psychotic symptom. It's not because they're selectively mute or they have another disability that interferes with their communication. It's also disorganized behavior where they're touching things and not really getting things done. So those are the main 3 psychotic symptoms that we give antipsychotic medications for. There are a group of medications called the traditional or conventional antipsychotic medications. And keep in mind that before 1958, we didn't have anything. So in over 2,500 years of there being descriptions of psychotic symptoms and things that we now call schizophrenia in the literature and in people's diaries, they, of course, didn't call it schizophrenia or psychotic symptoms, but these things have been described for a very long time, and we didn't have medication until 1958. So these were the first antipsychotic medications. There was Thorazine, that's the very first one, and actually nobody was looking for, let's make an antipsychotic. That was not a priority. The priority was, when this happened, in the early 1950s, a surgeon in France was looking for a better Benadryl. And if any of you have ever had surgery, you know that they usually give you an injection of atropine or Benadryl before you go in for surgery. And it's like, why do you get that? Well, those things dry you out. Surgeons are annoyed by moisture. And you do not want an annoyed surgeon. You want a very happy surgeon. Moisture makes things slippery, more difficult to manage. It makes things glisten, so you don't see things as well. And it's not it's not convenient to do some of those procedures with a lot of fluid on board. So they give you something to dry you out. It's for the surgeon's convenience. It doesn't really help you at all. As a matter of fact, it makes your recovery from your anesthesia a little bit more difficult. But, you need a happy surgeon. So this guy tinkered together this chlorpromazine, brought it to work and gave it to people. These are the days before we had institutional review boards and ethics boards that would really monitor these things. And he noticed that the people he was doing surgery on who happened to have psychotic symptoms were a little clearer after he gave them chlorpromazine. And so research was done for a couple of years on this as an antipsychotic medication, and thus Thorazine was born. That was our first antipsychotic. We got it here in the United States in 1958. Haldol, 1960, and the other medications thereafter. These medications are okay. They're not great as an antidepressant, and there's more. These are medications you may have heard of. Some of these they're not using anymore. We're hardly using Mellaril at all anymore because of the cardiac side effects of it. They're not making Moban anymore. But you might know that people have been on these medications for sustained periods of time. We also had cross-diagnostic use of it. When people are bipolar, where their moods go too high or too low, more likely too low, but they can have psychotic symptoms when they're bipolar, and we give an antipsychotic for those psychotic features. Any major mental illness, you can have psychotic features with. You can be psychotic with depression. You can be psychotic with bipolar illness. You can be psychotic with any major stressor, post-traumatic stress disorder, generalized anxiety disorder, not as often, but it can happen. So you may have had people who've been on a number of different psychiatric medications, and these older antipsychotics were the ones that were being used. The newer antipsychotics are called atypical antipsychotics. The very first one was Clozaril. It's new for us. Came out in December of 1989, technically 1990, in the United States. But it was developed in 1960, and it was used for 18 years in Europe until they had a major problem with it, and they took it off the market. Then we did research here in the late 1980s on Clozaril use, and it came on the market in 1990. It is still considered the gold standard of treatment for psychotic symptoms. It's the best. If your body can manage it, because some people's bodies cannot metabolize it well and they'll have difficulties with their blood components, it is the best. You have to have your blood drawn to monitor some of the side effects of it. Risperdal came out next. Then there's a long-acting injectable atypical antipsychotic called Constant. And the reason this is important is that people who had antipsychotic medication, that they refused to take the pills or they couldn't swallow the pills, there was a problem. Haldol and Prolixin, which are a conventional antipsychotic group, had this opportunity where you could inject it into a muscle, and then the muscle would gradually extract the medication and put it into the system, and the person would have use of that antipsychotic. It's called a depot medication, similar to a train depot, where you would store things and then gradually pull it out into the different train stations. We store the medication in the muscle, but Haldol and Prolixin needed to be suspended in a liquid in order to be injected into the system so it could be metabolized slowly. And Haldol and Prolixin has a lot of side effects. So when you inject it, it's there, and the side effects are there until they're worn off, which can take weeks. Some people get those injections once a month. But the liquid that it's put into is an oil. It's actually sesame oil, not culinary sesame oil. You can't cook with the stuff. It's pharmaceutical grade sesame oil, but it's very thick. And when you gave those injections, it really got a push on the syringe to get it in there. But over time, that heavy oil and the medication put into those muscles, and usually give them in the buttocks or the vastus lateralis. Those are big muscles that can be metabolized. But if somebody doesn't walk well, or they have a lot of spasticity, or they're not mobile and they're in a wheelchair, then you have to give it in the deltoid. And the deltoid is not a very big muscle. So over time, whether you do vastus lateralis or gluteal, the buttocks muscles, or the deltoids, you would form these sterile cysts. And cysts are not muscle fiber, so it would not metabolize the medication well. Plus, you have those side effects in the body for as long as that medication is in the system. And sometimes it would get trapped by fat globules, depending on the fat content of the person's body. Fat is not muscle fiber, so fat is not going to metabolize the medication like a muscle fiber would. It kind of slides it off to the side, And then when those fat muscles or those fat cells are expulsed or exploded in some way, then the medication might flood into the system, into the muscle fibers that are close to those fat cells. And then the person might have a tremendous amount of side effects from that injection. So those depot medications were all we had from 1962 until about 2002. And then Risperdal came up with their long-acting medication, which is in water. So Consta, you have to get the injection every 2 weeks. With Haldol and Prolixin, the choices could be every 2 weeks, 3 weeks, or once a month. And most people would choose once a month. But Consta has to be done every 2 weeks. But it's in water. It's a much easier injection to give. I've had a number of people who have had deltoid injections, and they don't form the same sterile cysts as, of course, the Haldol and Prolixin decanoates do, because they're not an oil, but also they're metabolizing quite well with the deltoid muscle. Seroquel's claim to fame is that it's sedating as a side effect. Zyprexa's claim to fame is that it's a very good antipsychotic. Chemically, it is the closest to Clozaril. So if people can't take Clozaril because of their metabolics in some way, then Zyprexa might be a good option for them. But Zyprexa's major side effect is weight gain. Clozaril has weight gain as well. Now, not so much with Risperdal or Seroquel, but Zyprexa's weight gain is quite notable, to the point where we usually, before we put somebody on Zyprexa, we teach them about some dietary changes that they have to make. And volume is the biggest help for minimizing the weight gain, but you're still going to gain some weight on Zyprexa. Used much in the past several months since it came out, because you must monitor the person for 4 hours after you give the injection. It's not very convenient for the person who just got the injection and for the clinician, because they're hanging out with each other for 4 hours, and that takes up a lot of time. Geodon is an atypical antipsychotic that was specifically designed to be an antidepressant and an antipsychotic. It's an energizing medication. I don't know whether I go into details about that, but I'll go back to it if I didn't. And Abilify is another atypical antipsychotic. Invega it's a metabolite of the risperidone. Laser drilled holes that have a plug in them, so you can take the pill and very slowly over a 24-hour period, you're routinely getting an insertion of medication into your system. And they have a long-acting called Systena. Saffris is fairly new. It is only available in a sublingual cachet. It's a little pill that you put under your tongue, and it dissolves in about 10 or 15 seconds. It doesn't instantly evaporate in the mouth like you would a nitroglycerin tablet or something like that. And you cannot eat or drink for 20 minutes after you put Saffris in, because it'll interfere with its absorption in your system. Fanapt came out at the same time as Saffris, and Latuda is fairly new. So these are all atypical antipsychotics, and they all have special features to them to make them, like, why would I use that? The newly approved drugs I have here is the Saffris and Fanapt and Invega, Systena, Zyprexa, Relprev, and Latuda. These are all the fairly new ones. And it is unusual for us to have fairly new antipsychotic medications, because many, many medications never make it out of the phases of exploration and research. Then there's some adjunct therapy that's very new. If you hear people talking about NAC, they don't call it NAC, they call it NAC. It's N-acetylcysteine. And it's over the counter. And some research, the jury's still out on this, but some research with small groups of subjects have indicated that if you add NAC to an antipsychotic, then the person would be able to resolve their symptoms more effectively. It's not cheap because you need a fair amount of it in order for it to work, and it's not covered by Medicaid or Medicaid Part D, and most insurance plans don't cover it. But people have found it to be helpful, and when the research comes out and is finalized about that, I'll certainly let you know what they say about it. And lamotrigine, it's an anticonvulsant that's also a mood stabilizer, but it's been found that if you add it to an antipsychotic medication, that it is very helpful in stabilizing people's symptomatology. They don't have the same fragility of psychotic symptoms that some other combinations would have, and they mix very well with all of the antipsychotic medication. And the other adjunctive therapy is sarcosine that people are still doing some research on, but what's come out and looks fairly good. So before I get into more details about the laser drill, which I've already talked about to some extent, let's take a break for 10 minutes. I know I have a break slide on here, but I haven't reached it yet. Let's see where I put it. Yep, we're going to move that break slide up so that I'm not overwhelming you. So let's take a break now for about 10 minutes. Okay, we're back. Did have a very good question that came up about the side effects that need immediate attention for the anticonvulsants. Excellent question. And I will make sure that I discuss this later with the next time I do this particular formula. The anticonvulsants can have side effects because of their metabolic features. You can have those side effects right away, initially, when they're put on the medication. They can have them when there's any dosage change, and what I mean by dosage change is you go up or down on your dose, but also it can be given at a different time of the day. You can have any of those side effects, and it can happen 2 to 3 years later. So you always need to be on the alert for that list of side effects that says needing attention, because it can happen at any time. One of the things that happens in our bodies is that our bodies change. I mean, sometimes it's like vicious, the whole aging process. But as we change just a little bit, how we metabolize our medications are going to be changed a fair bit as well. So, yes, excellent question. Watch for those things all the time. Actually, the technology that is here on this particular slide, we've talked about the laser drilled multiple compartment non-biodegradable capsules. For example, Invega is an example of that. There's also what are called flash tabs or cache delivery systems. That's exactly the same thing as caches and flash tabs. Saffris is a flash tab or a cache. Goes under the tongue, dissolves not instantaneously the way nitroglycerin does. Nitroglycerin, you get that in there and it just gives the person a real jolt. Long-acting injectables we talked about, the ones that are oil-based are the more old-fashioned ones, the ones that are water-based, with Consta right now. And then there's something called sublinguals. You put it under your tongue, but it takes quite a while for it to dissolve. So it takes longer than the flash tabs and much longer than like a nitroglycerin where it's just going to dissolve immediately. Cross-diagnostic uses. We've talked about this a little bit, but let's explore it a little bit more in detail. The antipsychotic is called an antipsychotic because its research was based on treating people who have psychotic symptoms, hallucinations, delusions, disorganization. It does clarify thinking. So you don't have to be psychotic to have your thinking be distorted. You can have a mood disorder that's very disruptive, like bipolarity, major depressive disorder, post-traumatic stress disorder. You can have some real problems with your thinking with those. You can have pain to the point that it's interfering with your processing of information, and it can clarify the thinking of a person who is dealing with a pain problem, either an acute pain problem or a chronic pain problem. So clarifying thinking can happen in many different diagnoses, not just psychotic symptomatology. We use it in dementia, whatever the current phrase is. We use it for agitation. We use it for people who have overwhelming physical problems and they're just not handling it very well at the time. So clarifying thinking is an extremely useful aspect of the antipsychotic medications. Reducing or eliminating hallucinations, of course, that's how it was originally developed. The reduction in hallucinations is fairly reliable with antipsychotic medications. The elimination of hallucinations doesn't happen with very many of them. Clozaril is probably reliably one to eliminate a hallucination. Reducing delusions, fairly reliable. Reduction of delusions. Eliminating delusions, we're talking Clozaril. Decreasing aggression. Antipsychotic medications, because they help people process information and they remove some of the distractions that people might have, that might be exposed to, can actually decrease aggression and make people less likely to lash out in an illogical or impulsive way. And some people who have developmental disabilities have a major issue with impulsivity and with aggression and lashing out when they're feeling overwhelmed. Just had it happen last week where a young woman was finally able to go from her residence to make a visit at her mother's house. Hadn't been there in a couple of years. And when it was time to go home, she just became very agitated. And this is a family who's lovely, and they're caring, and they're very understanding. There are some professionals in the family as well. They knew what they were doing. And they managed her aggression, her verbal agitation very well from what they said. But she just got violent. All of a sudden, she threw a stapler at her sister's head and cut her face, and she needed 3 stitches. And, grabbed her mother's hair and was trying to pull her mother around by her hair. Very aggressive behavior that was out of her ken. She didn't usually behave like that. And so this just happened last week, and one more episode of aggression has happened since last week. Not to that extent, but she broke a mirror in the bathroom and then tried to use the shard to hurt herself. So that's a level of aggression that's starting to get to be problematic, and we'll probably consider using an antipsychotic medication to treat this. Stabilizing moods. Now this was, it's a fairly new concept in antipsychotic medication, but we know that there are, for example, Geodon was developed to stabilize the depressive aspects of any psychotic disorder. And with a chronic illness like schizophrenia, schizoaffective disorder, depression, you're going to have these mood problems in addition to the psychosis, and we're just loading on more medication. So Geodon was developed specifically to address both of those symptoms. And we found out in general that these antipsychotics can stabilize the mood. And that's why you'll frequently see people who are bipolar also taking an antipsychotic medication in addition to a mood stabilizer. Or it might even, the antipsychotic medication might perform all of the features of a mood stabilizer, and they don't even need anything extra. Unlikely, but it has happened with a few people. So the issue for us is that it's called an antipsychotic medication, and when you explain to family members or to clients, you're going to be taking this medication, it's an antipsychotic medication. They're like, what's going on with that? I don't want to take that. It's not an antipsychotic medication only. It was just approved and indicated as an antipsychotic medication. But the cross-diagnostic using for these compounds is a very common aspect of pharmacology these days. Since probably 2000, and we're talking a good 14 years, and it's not going to stop, chemical compounds address a number of different issues. And because we're so complex as individuals, we really need that kind of flexibility. So even though it's called an antipsychotic, as the slide says, cross-diagnostic use. It'll elevate a depressive mood. Certainly Geodon will do that, but also you're going to see that with some other substances. Now, you're not likely to see Clozaril used for a lot of cross-diagnostic uses because of the blood work that's required. People don't want to do that. Someone who's bipolar and fairly well-functioning, someone who's depressed, someone who has obsessive-compulsive disorder, they're not going to want to come in every week or every 2 weeks for blood draws. So that's why it wouldn't be seen, although it would be very effective. Most of the time you're going to see things like Risperdal, Zyprexa, Seroquel to a certain extent, but much more likely Geodon, Abilify. They're going to buoy up the mood. It decreases overstimulation for people who have a diagnosis on the autism spectrum, because overstimulation as a sensory issue can be quite distracting and disturbing, and it interferes with people's clear thinking. And that's what the medication was built for. So it does help decrease overstimulation, which can lead to agitation. And it improves behavior because it helps people to think more clearly and to organize their thoughts and to take a step or two into their thought process about what's going on, regardless of their disability. They will be able to think a little bit more clearly, and their behavior will be better managed if they take one of these medications. Of course, the diagnostic category for antipsychotic medication is schizophrenia, schizoaffective behavior disorder. Schizoaffective can be bipolar, or so you have the symptoms of schizophrenia and the symptoms of some mood disorder, some affective disorder. And that can either be bipolar disorder or depression. So it's called schizoaffective disorder. Bipolar illness, a personality disorder or a personality trait, a strong personality trait, where the symptoms must be managed. One of the major criteria that we're using in the national standards around pharmacology with people who have personality disorders, especially borderline personality disorder, is that there has to be, and there is, a structure to how the pharmacology proceeds in giving people relief from micropsychotic episodes, from behavioral problems, from feeling overwhelmed, for having emotional problems that are contributing a great deal of distress to the quality of life. So the antipsychotic medications, and usually very low doses, has been very helpful with people who are very distressed from the symptoms, not from a major mental illness, but from a personality disorder or the strong traits of a personality disorder, and of course depression. The diagnostic category for an antipsychotic medication of autism is, like I mentioned before, it can decrease the overwhelming sensory experiences. It can help people think more clearly. It can affect their in a positive way, it can affect their thinking, their clarity of thought, and it can decrease some of the anxiety that people have frequently. Because these are major tranquilizers. That's the category that they were originally labeled. They help to calm and clear thinking. So people who have autism who are very agitated, or they get upset very easily by disruptions in their schedule, and behavioral interventions, which are required, that's never something that you're going to get rid of just because you're giving them a medication, really the behavioral interventions are not sufficient, that there is a sufficient amount of distress over and above what is acceptable, and that's when you would employ an antipsychotic medication. Asperger's is the same thing. When people are very distressed, they're having social contacts that are interfering with their abilities to function well. Obsessive compulsive disorder, which is an anxiety disorder, you need to have sometimes something that will calm and clarify the thinking, and that's what antipsychotic medications are made for. Other anxiety disorders, like generalized anxiety disorders, post-traumatic stress disorders, phobias, true phobias are actually quite rare, but you have these anxiety disorders, panic attacks, where sometimes you need something that has much more oomph to it, much more potency than just a minor tranquilizer. Seizure disorders, recent research shows that antipsychotic medication can be helpful in decreasing some of the overstimulation in certain parts of the brain. So partial seizures or generalized seizures, the overstimulation in certain parts of the brain can be calmed by an antipsychotic medication. That's one of the major diagnostic categories. Tics, and they are behavioral tics as well as verbal tics, like in Tourette's, can be treated with antipsychotic, most commonly treated with antipsychotic medication. We used to give Haldol to people who had Tourette's, and it was a problem. There was a baseball player who had Tourette's, and it really sedated him and interfered with his swing, and it made him stiff, basically. Not so much sedation, but it made him stiff. And so he wouldn't take it, and so he was having all these verbal tics. But now with the new medications out, new since 1990, there are more options, and the treatment is better without having a lot of co-administration issues in Tourette's. So that was the break. We took it. I hope you enjoyed it. I'll have to move this slide. Understanding the treatment options for autism, we're going to take a look at how autism is treated pharmacologically and non-pharmacologically. And I'll mention some of the new research, and we're going to discuss treating a symptom versus treating the syndrome. And I know you might find this hard to believe, but I have strong opinions about these things. Common problems and common medications, interactional difficulties that are rampant in people who have autism or anything on the autism spectrum. They can have overexcitation, overreaction, aggression, hyperactivity. They're uncooperative, especially if something is different. So, and you know these things better than I do, I'm sure. The symptoms include impulsivity, tantrums, peculiar speech that people might not understand, and it can't be varied to help communications. So the interactional difficulties of overexcitation, overreaction, aggression, hyperactivity, and uncooperativeness, they all fall in a similar category, so they will take similar medications. Overexcitation and overreaction, you're probably going to go more with an anticonvulsant medication. Aggression and antipsychotic, not always clozaril because we don't usually have that option, especially if they are on certain anticonvulsants. Like if they have to take Tegretol, you can't take Tegretol and clozaril. They don't mix well in the body, so they don't play well with each other. So we don't usually go there, although it would be very helpful. So there's other antipsychotics, newer ones that we'd like to use. Hyperactivity, antipsychotic, uncooperativeness, antipsychotic, anticonvulsant. Both of these things will calm down the overexcitation in the brain and help develop more pro-social behavior situations. The symptoms of impulsivity is usually responded to with antipsychotic medications and anticonvulsants, again because they calm the overexcitation of the brain. Tantrums, same thing. You're talking about impulsivity and some aggression. Peculiar speech, usually just an antipsychotic. We don't usually use an anticonvulsant for peculiar speech and communication problems. But even though this is a new aspect of pharmacological interactions of people who have developmental disabilities, the non-pharmacologic treatment for autism needs to be put into the forefront. The whole purpose of what we're doing with people who have autism is to help them relate to others, to help them feel more comfortable and for them to have satisfying relationships. We have to teach people who have autism how do you build a meaningful social interaction. If they don't have that ability, we have to teach them. If they do have the ability, all the better, but it is unusual with autism. There are strategies that we need to teach people for how to increase eye contact. You don't want them staring. You don't want them not blinking. You don't want them looking away all the time so that they aren't really accessing. And it's a very sophisticated concept. How much eye contact is appropriate? How much is over the top? How much is too little? It is a delicate communicative process, but we are very sensitive to it. When you're teaching people how to competently communicate, that has to be part of the program. Encouraging sincere affection and sincere expressions of joy and caring on an ongoing basis, where it doesn't come blurting out as an afterthought. And that's something that we routinely teach people. And when you have a lot of these 3 bullet things in place, meaningful social interactions, appropriate eye contact, sincere expression of feelings, when they have feelings about people, those actually develop neural pathways in the brain that will decrease over time their need for some psychiatric medication because they are malleable to a certain extent. There is some plasticity in the brain. Motivating and teaching, because sometimes people have amotivational syndrome, avolition, and they're not learning at the same pace that they previously learned at or that would be expected from their environment. So you can teach people, how do you say what you want? How do you express love? How do you express good, positive feelings? And how to take care of yourself or herself. How to find clients' motivations and interests. So you're going to be talking to somebody about discovering what are they good at? What do they enjoy? Do they like drawing? I'm seeing somebody right now, a young woman who drew absolutely beautiful, detailed, colorful, and highly accurate drawings of animals and did an absolutely beautiful job. And all of a sudden she just stopped. And it was very potent to have that drop out of her life. And so we talked about what was going on, and we gradually got her back to it. And there was a difficulty for her in not being able to perform that expression of drawing. And she's getting back, not all the way back yet, but it was a communication to us because she stopped doing something that she was very interested in. You want to motivate people to be dynamic and to have a learning experience that really does change with how they're changing. Because like I mentioned, their neural pathways will be reestablished. There are changes that we can make to the brain. No matter what damage is already there, we can get around it to a certain extent. And you want the learning experiences to morph and change and be dynamic with that individual situation. You want the individual to gain some skills that they need to be successful in life. How to remember, how to pay attention for a significant period of time, not just for a few seconds and then they're off someplace. And just learning how to stay in focus and how to cooperate with other people. That there are other people in the room and they need to be acknowledged, and that there is nothing bad that's going to happen to the individual because they're interacting with others. And a lot of people who have developmental disabilities have been traumatized to a significant extent, and there might be some catastrophic thinking at whatever logic level they are at that needs to be taken into account. So they need to be brought along slowly for exploring these new experiences. Speech and language development are always very important to increase communication skills. I need to increase my communication skills. I can't go a single day without thinking, you know, I probably could have said that better, clearer, better, slower. Everybody needs to be working on their communication all the time because human communication is incredibly complex. It's very demanding, and there are so many variables that can make a mess out of what you're trying to do. You're trying to say something to somebody, you're trying to do something for somebody, and there are hundreds of ways to misunderstand people and to misunderstand what people are, like, you are not clear to other people and you are not clearly getting the message that other people are giving you. So all of us need this. It's not just people with autism. But it might be a little bit more important for people who have autism to be able to improve their communication skills because they might have deficits that really interfere with their having a more satisfying life. Functional strategies for increasing verbal communication. How can they get better at talking in a way that really works for them and what they're doing in their life? Having somebody memorize, because they're very good at memorizing. I have somebody who almost has an eidetic memory. He sees the facial expressions, and I have the name of the feeling underneath it. And that really is the only way he can know how somebody else is feeling, is to memorize those facial expressions. That's a functional strategy for him. And then he can say the word. Gee, it looks like you are worried. Are you worried? I mean, he can't carry the conversation on very far, but he does feel very much better that he was able to nail that definition. The person says, yeah, I'm really worried. You know, I have to go to the doctor. And it's like, I got it, worried. Yeah, nailed that one. Interact, make requests, express. These are things that are important. I know I have the male gender on some of these, but forgive me. Interacting and making requests, not demands, and being able to handle the answer. If somebody says, no, you can't go out right now, or I can't take you to the dollar store, or you know, I can talk to you in a few minutes, but not right now, or I have to leave. Those requests not being met can be quite distressing. So there has to be a way to interact about being disappointed without it having a catastrophe. They need options for how to communicate these experiences. And it's never too late for anybody to learn how to communicate. In general, and I'm sure you all know this very well, continual education, continual training, and continual community support is very important in autism treatment. You're creating an optimal environment for people to learn what they need to learn in this world. It's not an easy process, but we have a lot of experts in this particular process, and we're, am I doing on time? We're continually trying to improve what's going on in the environment. It has to be comfortable, it has to be safe, and it has to be free from overstimulation to a reasonable degree. If somebody's overstimulated because the walls are beige, that has to be accommodated to. They can't just go repainting everything just because the person feels overstimulated. There has to be some adaptation that's functional in the world. Filter out nearly all of the most common distractions for the individual. Learn how to eliminate the push and pull control paddles that happen. Push and pull, very common in family interactions and sometimes in residences, where one person wants to do, let's say the person who has autism wants to do one thing and mother wants to do something else, you know, yes, no, gimme, no, and it's all push and pull, as opposed to saying, I hear what you want to do. This is what has to happen first. And that takes the whole push and pull out of it. So sometimes we're teaching the individual who has the disability, but we're also teaching the family members and the caregivers and the residential aides, you know, whoever we can get access to. People need to know how to extract themselves from a control battle. Decisive and useful handling of challenging behaviors. Some people who have autism they have behavioral problems. They have to find a way to have different behaviors and more competent ways of communicating what's going on with them, the reason why they have their behavioral issue. And there have to be practical techniques for preventing the behavior. And the practical techniques can come from staff observing what's going on with the individual. They usually do this. I have somebody who hums just before she's going to lose her temper. It's a little bit of a hum. It doesn't last very long. But knowing that that's there, people can intervene and try to lower the distress level for her. Now, I want to talk about generic compounds for a few minutes. The FDA, this is a number of years old, but it comes up in different ways since then. Generic compounds are the chemical name for a compound. We usually have a trade name and a chemical name. And the chemical name, the generic name for any compound, is formed from its chemical basis. So you have a whole group of medications that belong to this chemical class, and so they're going to have similar generic names. And then you have the trade names. The trade names are established by marketing research. If you've ever gotten one of these in the mail, they send you a list and they say, here's 5 names of medications for a headache. And they send you a check for like 20 bucks or something. And they say, please return this survey to us. And they'll send it to a cross-section in the country, in the age, with both genders, and they just organize it into a market plan. And so you'll pick the name of the medication that makes the most sense for you, that you would remember, that would kind of fit with what's going on with it, and that's how the trade name is established. That's the science of it. The science is marketing for trade name. But trade names are given to compounds when they first are put on the market and when they've been patented. So the FDA gives the approval after the human research has been done, and they say, okay, this is your launch date. This is when you can put it on the market. What's the name? What are you going to give it? So like haloperidol, that's its generic name, its trade name is Haldol. And the patent allows that company to make haloperidol under the name of Haldol for X number of years, depending on what research they did. If they just did research on adults, and it's like 9 years. If they did children, maybe they'll get 11 years or 13 years. But then it comes off patent. When it comes, and the reason they're doing the patent is to reinforce drug companies for doing research and development. Because they got to pay researchers, they have to pay for all of the lab equipment, they have to, for years, and they have to pay for the manufacturer, and the company, the factory, the distribution. All that stuff is very expensive, and it takes years and years to put something on the market. And at the very last day, the FDA can say to them, no, we're not going to market this. And they just spent 14 years of money and investment in a medication that the FDA will not allow to be marketed, so zero money comes back to them. So 1 out of 1,000 medications will make it to the market, and so they want to, by patent, say, okay, you have the right to make this medication. Nobody else has the right to make this medication until your patent expires. And they give the patent a little bit extra length if you do a little extra research on it, like with children or special groups. Very difficult research to do. Then when it goes off patent, then anybody can make it. And when anybody makes it, it's called a generic compound. So when it comes off patent, when and why is a medication offered in generic form? Well, it's when the patent expires. The U.S. rules about generic compounds are very strict. You must have a patent for a certain length of time. And keeping in mind that patents for a device are much shorter, it's usually only 5 years. And they want you to improve your devices. So you can't just say, I have a patent on this device and I want to improve it. I want to renew my patent in 5 years because they're going to charge you a lot of extra money to get that patent put through. They want you to improve on this device, but you're still only going to get a 5-year patent. But with medication, you really can't get much more than 13 years. And typically it's 9 years. So all of the years you put into developing that medication, you're not going to get all your money back for it, or if you do, it's luck. So those are the U.S. rules about generic compounds. But there's also a rule about how much of the active process, the active compound, can be in a generic product. For example, if you make Risperdal, and risperidone is the generic name, and it comes off patent, but the Risperdal name used a certain color to the dye, to the pill, and they used a substrate, what holds it together, and it's special. They did the research on it. Comes off patent, now it's generic. Anybody can make that chemical compound of risperidone, but they don't have the same dyes and the same substrates. So what the FDA says to them is, okay, you can make risperidone, you have to call it, you can't call it Risperdal, you have to call it something else, and you can have a variable amount of the active medication in there, which was alarming to a lot of people when they first found out that that's the way the FDA works. But that is the way the FDA works. And there is an amount of variability in there. We'll go over that in a minute. And if you know that a generic compound has some variability in how much active medication is in that pill as compared to the one that's still made by Janssen Pharmaceuticals and called Risperdal, but now you have somebody who's taken risperidone, the generic kind, there is a difference. People say, oh, it's exactly the same stuff. Well, it's exactly the same medicine, but it's not the same dye, it's not the same substrate, and sometimes it's not even the same amount of active medication. So when people say, I'm taking a generic and it's not the same, believe them. Especially people who are very sensitive, like people with schizophrenia, schizoaffective disorder, people who have bipolar illness, people who have autism or any developmental disabilities, they're going to be sensitive to the generics. If they took trade before and they got changed to generic, they very likely will see a difference. So we talked about research and development. Country of origin is an interesting process, and that's involved with this generic as well. When we make drugs in the United States, we have a lot of control over the factory and the cleanliness and the distribution, the transportation system, but other countries are very different. Denmark is very different, Japan is very different, what's happening in the Sweden, Norway, Finland area, Italy, all these countries have very different rules about things. The United States has the longest research period of any country on the face of the earth. You want to put a drug on the market, you're going to put it on the market early in Europe, maybe 24 months of research. But in the United States, 9 years of research. So a lot of companies choose to make their product in another country because it's cheaper and easier to do that. And the FDA has to take that into account. How was this drug made? How competent was the research? How long-term were the implications of it? So that's why the country of origin has become important. The patent longevity we already talked about, and the pharmaceutical compound production. What's the substrate? What holds it together? What is the dye? And the dye lots change frequently. Do they make their own dye lot? Do they just buy whatever's cheap on contract? The economic realities is that when you make a generic drug, you have not put 9, 13, 15 years of research and development costs into your drug. So you just have this chemical compound that you're making, and it's much cheaper because you don't have to pay all those bills for all those years. So that's why generics are cheaper. They didn't have to do the research and development. They don't have to have the special dye and the special substrates that frequently have to be put into place with a trade name. And the practical implications is that people are going to notice a difference. So applying these pharmacological attributes of generics to what we do with people, there are pros and cons. The bioavailability, how available is it to your body? There is a formula. Give it to you. By the way, one of the countries we're having a big problem with is drugs that are made in India. More so people say, oh, what's going on with drugs from China? Actually, they're not so bad. The biggest problem is India. They have a lot of contaminants in their generics, and something to be watched for. And that's what happens when people buy drugs online. You don't know where it's coming from. Its country of origin may very well be India, and you could get a lot of junk in your med. Let's see. The bioavailability is how is your body going to be able to access that drug? That's all that means. Bio is life, and availability is, how much can this life body, this life force, get into what's going on? And it's basically metabolism. Some generic products are easier available because the dyes and the substrates are not as complex. So it can get into the system a lot faster. Some people are very sensitive to the differences. I have somebody who went to generic, she takes Nardil, and Nardil a couple of years ago decided that they needed to be gluten-free. I mean, the pill is like this big. How much gluten could there possibly be in there? But they made a decision, so now they can advertise themselves as gluten-free. Well, now it doesn't work. The generic version, which is gluten-free, doesn't work for her. So just that one change that they made in the pill made a huge difference in her bioavailability. Apparently she needs gluten in order to go that way. So the value of using a generic is that it could have the features to it that the individual's physiology really relates to. The point of concern is where did it come from, and am I going to see a difference between trade and generic with this person? And do I need to change the dose? For example, one of the laws that the FDA has put out is that you can vary how much of the actual active drug is present in that pill and still call it that pill. So for example, if I was going to give you 100 milligrams of drug A, trade name, drug A, and drug B is the generic form of that drug, there might, and it's still a 100 milligram pill, but it might not have 100 milligrams of medicine in it. It might have 80 milligrams of medicine in it, and that's just fine. With the FDA, there's some wiggle room. Somewhere between 25 and 33% can be varied in it. So if I have somebody who's been doing very well on 100 milligrams of a trade drug, and now they have to go to generic because they don't make the trade anymore, it went off patent, or because their insurance doesn't cover it, or because their prescriber wants them to be on this generic form for one reason or another. They might not be getting 100 milligrams of it, and their symptoms might get worse. So they might need to go up to 120 milligrams or 125 milligrams of the exact same drug if it's available to make up for that difference that can happen with a generic. So that's one of the practical points of concern that we have to keep in mind. Transitioning from brand name to generic is always an issue. Staff need to observe what's going on and try not to do too much of that at once. I would prefer one drug at a time. Sometimes you don't have that luxury, but like I mentioned before, I do have clients who are very sensitive to those transitions and they don't work well. And it's good to know which one is it, which one has to be trade. Transitions from one generic formulation to another is also a clinical issue because one company that makes a generic version might use a whole bunch of one dye and a whole bunch of baking soda as a substrate. And then this other generic drug company makes exactly the same drug with exactly the same potency might use a different set of dyes and a different substrate. And the person could be sensitive to those differences. So even any transition is something that has to be watched. So here's the FDA rules about generic compounds. The rule is that the trade dose can be considered what's bioequivalent in the U.S. if it's 80% or all the way up to 125% of the trade dose. So if you're taking 100 milligrams of a trade drug, by law in the U.S., 80 milligrams to 125 milligrams could still be the same 100 milligram trade bioequivalent medication. So if somebody is very sensitive to side effects or their symptoms are responsive in a very narrow range of medication, that's the problem with a generic. Got to watch them like a hawk and keep in mind that 80% of that dose is not going to address their symptoms, or 125% of that dose might give them too many side effects. So just keep it in mind. Generic anti-epileptic drugs. It's been suggested that AEDs need to be exempt from substitution because you finally get somebody stabilized on the anti-epileptic drug, and they're very hard to stabilize. Whether you're doing for seizure management or for mood management, doesn't really matter. Anti-epileptic drugs are a delicate process. And if you then say, all right, now we're shifting it all to generic, that's, we're fighting that because we think AED should be exempt. That switch is very difficult. It could be associated with the increased use of an AED, or so that people using more and more AED, or an increased use of non-AED medication. So it could end up hospitalizing people. And if we can prevent a hospitalization, it's number one on our list, quality of life and reducing their hospitalization rates. So basically what it means for you is that you need to be aware of a change from trade to generic. Because this is a sensitive population, they're probably going to pick up on that difference. Manage the transition as much as possible. By manage, I mean, can you do one at a time? It would help to smooth out some of the complexities. Watch what's going on with the individual. Talk about what's going on with the individual. The relationship with caregivers is very important. That individual trusts you, shares information with you, is performing their regular duties in front of staff members, precious information that can be very helpful and reassuring to the individual because they'll know that you're remaining up to date on these options. And it may change. This FDA rule has been in place for a number of years, but it was different from the previous FDA rule about generics. So we'll keep our finger on the pulse of that. The new trends in teamwork has been quite well researched lately with people who have developmental disabilities and all of their caregivers. So it's important for us to pay attention to that because the teamwork that happens with people who have developmental disability actually can shape what happens with the pharmacologic outcomes. Drugs are not everything. I mean, I know I talk a lot about medications, and I have 2 other of these modules that talk about pharmacology. It is very important their neurotransmitters and basic functioning in the body is so distorted that there's no way that the person's body can physiologically get it normalized, that you need to have some outside input chemically to approximate some normal functioning. But there's so much more that needs to be done in addition to just giving somebody a pill in order to make the pill work better. It's part of a whole process. So the interdisciplinary communication about anything that's going on new with the medication needs to be paid attention to. So interdisciplinary communication is vital to best practices. You cannot be the best at what your individual discipline is without input from somebody else, from another perspective, from another point of view, and from everybody else who's dealing with that individual who's getting services. So vital communication. What needs to be communicated amongst ourselves are the things that we observe. Frequently, we see a lot, and sometimes we don't take a lot of credit for what we see. We don't absorb that as much as we should. So we need to communicate amongst ourselves on a regular basis, team meetings or family meetings or residential meetings. You need to make a productive meeting about it, where you're not just meeting for the sake of meeting, but you have something that you're specifically going to be talking about and goals for those communication sessions. And if there's been a change from generic to brand name or trade name or the other way around, then that needs to be discussed. Everybody needs to know that that's what's going on, because very precious information can come out of that. Besides the behaviors and the observations that you're going to have, there are impressionistic feelings that people have when they work with individuals who have developmental disabilities and work in any specialty area. And those impressions are valuable data, needs to be shared. Communicate what you think is going on. You might not have a hard and fast definition for what you just saw, but you can say, you know, he's different, and I'm not exactly sure what it means that he's different, but nothing else has changed, and this is just something I want us to be paying attention to. So it's a very good process to be on top of, that your impressions are acknowledged and validated, and that you acknowledge and validate other people's impressions, because all it could do is help with the communication. We're a unique group of caregivers. This is a specialty area that not a lot of people have any skill at, and they might not understand where we're coming from with this. But we have to share information in a way that recognizes everybody's skill level. Everybody who deals with this specialty area has something to offer, and we all need to absorb that. And you all probably do, but I have to say it out loud. You have to acknowledge that there have been previous difficulties in training people, new people to the business, or changes in how things are done, people who have been in this specialty area for a very long time, but big changes have happened. How is that trained about? What kind of information sharing happens? What kind of navigating the transition that happened in this specialty area has been accomplished? And how well has it been accomplished? So communicating that information is very important. Incorporate how to observe behavior. Some individuals who work with this population are very focused on behaviors, and they communicate them. They're out there with them. But some individuals, they just absorb that information and they don't put it back out there again, and needs to be discussed. It's not all just behavior, it's behavior and communication. You have to arrange the information sharing in a logical way. Like I mentioned before, have a focus for your meeting, have an intention, like an agenda. It doesn't have to be a printed agenda, but just to say, we're going to talk about Adam and we're going to talk about Betty, and both of them need to have some concrete tasks that they're going to be able to accomplish in the next month. What is it going to be? And we want to talk about it and make the best possible task list for them, and just as an example. And be flexible. So if a crisis comes up when you're supposed to be having a meeting about Adam and Betty, that you are able to talk about Cheryl in such a way that it's competently communicated. So your team needs you. And everybody who has a developmental disability has a team of people who are interacting with them. And also, you need your team. This is a way of communicating that's helpful if you're all doing it together. And ask yourself, does everybody else in this team know what's important? That I need to know these things, that this is what really helps me do my job better. And the most helpful pieces of information for anybody, of all the people I've asked and talked to over the years, is observations on medication effectiveness. Do the meds work? Is the pharmacology doing what it promises to do? What is the timing of the behavior that you're seeing? And is there any side effect that could be attributed to these medications? That's something that everybody needs to know about. It's an important process. So examples of medication effectiveness and examples of side effects. Clients' communication, very difficult to follow today due to slurred speech. And we talked about the slurred speech being one of those side effects that needs to be addressed quickly. Could mean a couple of different things, but they need to be addressed. So that's your observation. That's what should be communicated, either in writing or electronically or verbally. Client's communication is difficult today because there's slurred speech. This client repeatedly demonstrates hyperactivity by his inability to sit still. There's a side effect of many medications, antidepressant and antipsychotic medication, as well as some medically based medicines, that cause a side effect called akathisia. When we stick A in front of something, it means it's not happening. And kathisia means the ability to sit still, or the perception that the person can sit still. So akathisia means that person doesn't feel like they can sit still. So they're moving around and they're feeling uncomfortable, and they might be pacing or dancing in such a way they can't stop. That's a side effect. We can address that when it's at its lower levels. But when it raises up, when akathisia is at a severe level, the person is very likely going to be violent or aggressive. The client might describe his feelings as sometimes my back tightens up or I get tongue-tied when I try to talk. That can be a serious side effect of some psychiatric medications. These dystonic reactions. DYS means bad, and tonic is tone. Bad tone. It's a muscle spasm. So the trapezius muscle, which is a kite-shaped muscle that covers our back, big, strong muscle, that goes into spasm. That person is going to be hurting. They're going to feel terrible about their meds. Look what my meds did to me. And, you know, they're just going to be all stiff and uncomfortable. And sometimes the tongue is the muscle that goes into spasm, and that interferes with their speech. The client noted they have rigidity and tremor. Rigid or tremulous extremities can be side effects of the medication. That's something that needs to be communicated. So how can you keep the team observations uppermost in everybody's mind in the team? Is communicate the benefit of why they're taking these medications. The timing of the communication. When is the best time to talk about these things? Not as people are rushing out the door or going to go to another meeting, or they're going to go into a performance evaluation, and so they're preoccupied. The timing is important. It needs to be done at a time when it's best for everybody. And what are some memory enhancers so that you can keep your observations intact and share them? The steps for communication, very straightforward. Describe, why should I do this? Well, for me, I need to know what you see because I don't see it. I'm not there all the time. And this is the information I need in order to do something to help this person. And why is it important? So it could be a quality of life issue, but it also could be a safety issue. So define the steps of the process. Describe, what do you want? What kind of observations do you want? You know, get a clear picture of what you're asking, and build upon what they already know. You're talking about your team members. You know what they know, and you want to build on that. And you want to give them a sense of importance about this because it is very important. Clarify what they just heard you say, because I can be sometimes unclear about things, and so I will ask, gee, what did you hear me say? Explain the benefits, review with them what they heard you say, what do they think they need to be doing, and show your appreciation. People are putting extra effort into communication. They're putting extra effort into doing something that you would like them to do. Show your appreciation. Lots of ways to do that. You can be straightforward about it and just say, thanks, I really appreciate you doing this. But an important feature is to recognize that people are putting effort into something that you find important. So this is how you stay current. You're obviously doing some of these things: video conferences, conferences and seminars, webinars, journals. Now, journals now are mostly electronic, so it's pretty easy to stay up to date on them. If you have internet access, you don't have to have special access to something called PubMed, PubMed.com. PubMed is a pretty straightforward public forum for academically published articles, journal articles. You can put in a topic, you can put in an author's name, you can put in a journal name, and you'll get a list of hundreds of thousands of things. Just type in autism into PubMed, 15,000 articles are going to come up, and they'll go back several years. The most current ones are first. So journals are much easier to have access to than they were in years past. Colleagues, everybody has wonderful experiences that can help expand your experiential database. Empiric evidence, what's going on with research in your area? What is the population of researchers who are doing things in your specialty area? Participate in research when you have a chance, even on a very low level. If you don't want to go full bore into doing research and all of the nuances of it, you could be very helpful in collecting data on something. Ask around and see who's doing what. See if you can help. Of course, association membership, advocacy groups, the autism advocacy groups are very active. I find them very helpful in many regards. The National Alliance for the Mentally Ill, NAMI, mental health associations, professional organizations, very helpful, and it always helps to listen to other people. So that's the basic content, and these are, I have them labeled test questions, but I think they're called polls. Yeah, they're called polls on your, they should be popping up. And so question number 1, the best way to reconcile a recipient's medication regimen, and we didn't specifically cover this, but it's something that you can kind of figure out. A, go over the recipient's current medication, remind the recipient what he is taking. B, write down everything the recipient is taking on arrival with your services. Track the changes throughout care. Highlight what should be taken now and review with the recipient and the caregiver. C, clearly review what medications the recipient should be taking with his or her caregiver. And D, have the caregiver bring all the medications to the office and discard those not being used. So the answer, the correct answer, there's 4 answers there, but of course the correct answer is number 2, which is B. Write down everything they're taking as soon as they come into your service, as soon as you're aware of them needing your services. And just track what's going on throughout their care and highlight for them what's taken now and what they should be taking. The recipient and the caregiver need to go over that. And on the next one, I'm going to give you a little bit more time before I give you the answer. So I'm not just jumping in and spoiling it for you. Spoiler alert. Question 2. A developmentally disabled client is also being treated for depression. An expected reaction to the antidepressant. And we didn't specifically talk about this either, but it's intuitive. An expected reaction to the antidepressant after 4 weeks of treatment would be no significant change in so short a period of time. Some medication side effects, complete resolution of depressive symptoms, or D, a reduction of the depressive symptoms the patient was exhibiting. Should have changed that to something else. So take a minute, and I know we didn't talk about that in detail, but we did talk about psychiatric medications. And what do you think would happen after somebody is depressed and they needed to be pharmacologically treated and it's only been 4 weeks? So the correct answer is 4, which is D. You're going to see a reduction in 4 weeks of the symptoms. That's all. It's not going to completely go away. It's not going to have no effect at all. If it does, it's not, it's not the right med. And there might be some side effects, but what you're mainly going to see is a reduction in those depressive symptoms. So this is that FDA generic question. Which of the following is the amount of drug absorbed per the amount administered? So we talked about bioavailability, we talked about bioequivalence, drug absorption, and dosage. So the correct answer is number 1, which is A, bioavailability. How much access to that compound does the body have? Question 4. Using the FDA bioequivalence rule, which dose of a generic medication would be considered equivalent to a 100 milligram dose of a brand name medication or trade? Same thing. Brand name and trade name are interchangeable. So take a look at those 4 options, 100 milligrams, 80 milligrams, 30 milligrams, or 60 milligrams. And let me know what you think of what would be considered bioequivalent according to the FDA rules that are currently in effect about generics. And the answer is 2, 80 milligrams. If I was taking a 100 milligram trade drug and I got switched over to generic, and 80 milligrams of the drug would be considered equivalent according to the FDA rules. It might be labeled 100 milligram pill, even though it only has 80 milligrams of that medicine in it. That's what the law says. All right, and the last poll question. Recipients must be observed for which of the following medication impacts? What do we want to see? The effectiveness, the length of time until you see an impact, side effects, or how long it seems until it wears off. So take a look, of those 4, which do you think would be a must for observing? And it's all of them. I'd like to know everything. I definitely want to know if it's effective. I definitely want to know how long has this person been taking this med and when did you see the difference? Did you see the impact? Did you see their depression going down? Did you see their thinking clarify? Did you see their aggression be minimized? Did you see their impulsivity be shaped a little bit by their environment? Did you see them adapt a little better to their circumstances? Is their mood more stabilized? What are their side effects? Are they drooling? Are they stiff? Are they tremoring? Do they have that restlessness? I want to know what the side effects are. And is it wearing off too quickly, or is it taking forever to wear off? These are all things that are very important for us. So at the conclusion, like right now, there's a survey that's going to pop up on your internet browser, but if you don't see it, just follow the link. It'll be in an email that you get tomorrow. Is it tomorrow, or is it tomorrow Monday?
At midnight.
Oh, midnight. So if you don't see the survey, just follow that link. And any questions or comments you have, and I have questions, but if you have questions for Lisa, that's how you get a hold of Lisa. And we have time to have me answer questions.
And I do have a question from Leslie, who would like to know your thoughts on sudden death with Clozaril alone or added to SSRIs.
Okay. Well, I can tell you, Leslie, I have thoughts about everything, and I don't have a hard time discussing them. Sudden death is a problem with anybody who has a psychotic process, most specifically people who have schizophrenia, to a lesser extent people who are schizoaffective. So whether they have a developmental disability or not, people who have schizophrenia die 25 to 30 years earlier than they're supposed to, regardless of the medication they're on, and we don't know why, and we call it sudden death. It's a very disturbing, very problematic issue. We've done a fair amount of research on it. A few years ago, some of us had the bright idea that maybe Maybe they have a different blood component that makes them die so early. Usually it's cardiac, but we don't know why they weren't having a cardiac problem before they died of a cardiac problem. So you'd have a 36-year-old who would die. Why is that person dying? I just saw him 2 weeks ago. He was perfectly fine. So we did this. We tested over 500 people with schizophrenia for this particular blood component, thinking that it was a little higher, and maybe their blood was a little thicker and a little stickier, and maybe it made it much more likely. No, they had exactly the same blood components as everybody. So that idea was complete bogus as far as that research was concerned. So sudden death is an issue. It's been going on for decades. It's gotten much more precise because we are doing research on it. We used to think that people who died early died a few years earlier than they should have of sudden death. But now we know in the past 2 years that it's much more specific. 25 to 30 years earlier than they should be dying is a tremendous loss of life, and we don't know why. Okay, having said that, that's a diagnostic relation. Now let's add the meds. Happening with Clozaril or happening with Clozaril and an SSRI, a selective serotonin reuptake inhibitor. SSRIs and Clozaril blend very nicely, so they're given frequently together. But if you have somebody on Clozaril, the chances of them being schizophrenic are fairly high. So their sudden death is already on the table as an issue because they have schizophrenia or likely have schizophrenia, and they are at risk for dying early. Dying early because of the medication is highly unlikely. That's never been borne out in any research or any psychological or pharmacological autopsy that we do on people. Frequently, people who are on Clozaril who have sudden death because they have schizophrenia have a tremendously high level of Clozaril in their body. But, and my first autopsy was like, that is a really high level of Clozaril. What happens? Well, it just accelerates and it goes right off the charts when the person dies. It stops being metabolized and the metabolites pile up. And so it looks like a very, very high dose of Clozaril, and that's not what they were at. It's not like they overdosed on it or anything. So in terms of an explanation for why somebody would die on Clozaril taking an SSRI, you don't overdose on an SSRI. You don't die from taking too much Clozaril. Most you can do with that is have lots of drooling and probably a seizure. Cataplexy, which is a cardiac and muscle side effect of taking Clozaril, usually doesn't lead to death. So the most likely explanation, not knowing the details of the case, is that it was probably sudden death from the diagnosis of schizophrenia or something similar, as opposed to the treatment for the diagnosis the person had. That's what I got.